I'm Adam Greathouse. I am ASTRO's Director of Health Policy, and I'm joined here today with Dr. Amar Rewari. He is ASTRO's Health Policy Council Chair. He's also heavily involved in our RUC participation, the AMA RUC, and he's also the co-host of the podcast Value Health Voices. So we're excited that he has agreed to join us here on this podcast today rather than his own. So Dr. Vari, the Medicare Physician Fee Schedule final rule for next year just came out on Halloween, and originally we thought it was a little bit more tricks than treat. Some of you may have heard already that the wrong data file was uploaded with the final rule on that Friday night, and so over the weekend, all the medical specialty societies that care about this were scrambling to figure out what that meant, only to come to find out on Monday that they had uploaded the wrong file and they corrected that. And so then we could take a deep dive with the correct information. And so the differences between Friday night and Monday afternoon were a little bit night and day. But overall, this was a really big rule for radiation oncology. Lots of stuff to unpack here today. One of the big items being the new radiation treatment delivery codes. And the other being the efficiency adjustment, which kind of impacts the whole house of medicine. Um, but with the new delivery codes, there's a lot of history here, and I was wondering if you could kind of unpack some of that for us. Where did we come from? How did we get here? And what does that mean?
Yeah, thanks, Adam, for having me on. And yeah, it was surprising to see the rule dropped on Halloween surprise, and especially with the government shutdown and all. I was really not expecting that, but there you go. They made some errors and they fixed it, I guess. So, in terms of the history behind these codes, yeah, we've been having these G codes for about over a decade now. They came about in 2014, 2015. And the idea behind them is at that time, we had to go back and create new codes for IMRT and treatment delivery. And we split IMRT into simple and complex IMRT and different treatment delivery codes. It got approved by the CPT panel. It got approved by the RUC. Valuations were set. Went to CMS, and CMS said, no, we don't agree with these codes that you proposed. And there's a lot of reasons for that, which we don't need to get into. But ultimately, they didn't agree with the codes. And so because the old codes were deleted, they created new G codes, which ended up being how we do treatment delivery in the freestanding setting. And in the hospital outpatient setting, they ended up using the new CPD codes we created. For the last decade, we had these two different ways of billing treatment delivery in radiation oncology. And it actually worked in our favor, I'd say, in some ways, because um, as we were looking at the new alternative payment models, the RO-APM that CMMI had put out, which was looking at a bundled payment, we said that we would not want the G codes to be revalued during that time. And so when the RUC would push on us to go ahead and revalue our G codes, we said we needed payment stability because you needed to have a control group to compare the new payment model against. And so if all of a sudden your control group changes and those values change, how do you know if the new payment model is going to be successful? So we were able to advocate for keeping the G codes unchanged for a long time. But ultimately, when the RO-APM was indefinitely extended, the RUC came to us and said, now, no more delays. You have to do this. So revalue the codes. And we said, well, you know what? Instead of revaluing the codes, let's just create new codes that we think accurately represent what we do as radiation oncologists. And that's kind of how we got to where we are. And in the last year or two, both ASTRO and ACRO, I led an effort to create these new codes and get them valued through the CPT RUC process.
Yeah, and I didn't say his official RUC title for Astro, but Dr. Vari is Astro's RUC advisor, and so clearly was heavily involved in all those changes. And I mean, kind of long story short there, I mean, radiation oncology had a really good run with those G codes over a decade without any changes is kind of unheard of if you have any kind of insight into how the CPT and RUC processes work. So it was a good run. It was bound to happen one of these days, and you led a great effort on behalf of the specialty. Um, One of the surprises, I think, when the proposed rule came out earlier this summer, we suspected they were going to accept the new codes, the revised codes, weren't so sure how they would be valued, and they kind of threw us uh, for a loop there and proposed this idea to link the rates under the fee schedule to the HOPS setting, the Hospital Outpatient Prospective Payment System. We weren't expecting that. It took a lot to kind of dive into that and see what the impact of that proposal would be. But in this final rule, they are finalizing that crosswalk or linking the fee schedule rates to OPPS. Can you tell us a little bit more about that?
Yeah, and I think for our listeners, viewers, I think it's really important for people to realize what a win this is for our specialty and for the advocacy that was done by ASTRO. So the reason we've been pushing rocker is for two things. One is because in radiation oncology, everything we do is getting hypofractionated. So for every type of treatment you do, you're doing less treatments, which is obviously going to put downward pressure on reimbursement. But the other thing is in the last decade, we've seen declines in payment in the physician fee schedule, while the hospital payments have actually maintained and actually gone up. And so in the Rocker proposal, we were saying we should have site neutral payments tied to the hospital payments because they're more accurate, because every year those inputs of expenses that the hospitals pay for linear accelerators, vaults, what have you, gets aggregated across the country and compared to a charge master and annually corrected. So it actually is accounting for real charges and costs to us as radiation oncologists, unlike the fee schedule. And so with this, historically, the way we've been paid is practice expense has been associated with receipts we have to submit. So we had to submit the receipt for what a linear accelerator cost, what a vault cost, the staffing costs associated with delivering that therapy. And we, radiation oncology, are the most capital expensive specialty in the entire house of medicine. So our new inputs for linear accelerators and for the vault are way higher than the rest of capital expenditures in the house of medicine. And so there's this concept of budget neutrality where everything has to be budget neutral because it's a fixed pot that Congress gives Medicare. And so if all of a sudden one specialty's practice expense is so high, it has to relatively come at the detriment of our other codes potentially, have to go down within our specialty. And also overall, we may have to be rebalanced compared to some of the other specialties. So what the CMS did by doing this is they've now taken us out of that cycle of being forced to be in this budget neutrality system with our practice expense for treatment delivery. So we are now excluded from that and we are tied to the HOP system. So while right now some of these APCs may not be the most ideal APCs for some of our, like let's say our level 2 77407 treatment delivery, over time, because it's going to look at actual costs, we will actually come out ahead than being on that downward decline over as we have been over the last 10 years. So this is probably the biggest win for radiation oncology, I'd say in the last 20 years, being tied to the hospital payment system.
Yeah, and just to reiterate, that's just for those revised delivery codes. But yeah, those are all great points. And when you talked about having to submit receipts for all of those pieces of equipment over the years, like it's incredibly difficult to get access to those invoices in a format in which that the agency would accept. And so getting us out of that for at least this set of codes is a really big win. So yeah, all great points. Um, in a similar vein, though, it was obviously a busy couple of years for ASTRO and ACRO working on these codes, but we also worked on some other codes, not just the radiation treatment delivery, but also the superficial radiation treatment delivery code set. There's a lot of history there as well, but the agency accepted some new codes and made some big changes there. Could you elaborate on that a little bit more?
Yeah, definitely happy to. One of the other things I did want to make sure we bring up is that because of everything that happened with the treatment delivery and the conversion factor updates and getting us out of budget neutrality and how we get rebalanced, all our other professional codes have all gone up significantly, anywhere from 3 to 10% across the board, whether you're talking about IMRT, SBRT, weekly management, dosimetry, all our professional charges have all gone up also. So also a huge win.
And like, yeah, bigger increases than, well,
Then,
I mean, obviously we've only seen cuts in the past several years, and in
yeah,
my time at Astro, we've never seen increases like this.
no, exactly. So I did want to highlight that. But yeah, to your question, I think one of the other things we as a specialty face is encroachment up in our code set by other specialties, and which is not a bad thing. But what happens is if with the ruck, if another specialty becomes the predominant user of a certain code, then that code automatically triggers a review from the RUC saying that the dominant specialty provider has changed. This code's been flagged. It needs to be resurveyed. And then it's going to be resurveyed by that dominant specialty, which might have a different process of care and different expenses. And so the value of that code can go down. Our codes are valued as high as they are because most of them are delivered in rooms with a vault and with a linear accelerator. So with superficial radiation therapy, what's happened over the years is practitioners on the dermatology side who use their machines to do surface radiation therapy were using the simulation codes, sometimes daily or very frequently, which we had advised against for years, but they're very lucrative, as well as daily ultrasound guidance. And so what we decided is when these codes now became the dominant specialty was dermatology, and the RUC once again said we have to review these codes. We worked with the Society for Dermatology to create new codes that accurately accounted for the true practice expense associated with the equipment for delivering surface radiation therapy and accurately accounted for the process of care with doing that. And so they now have new codes for simulation, for ultrasound guidance, and for the delivery. And their delivery has actually gone up that represent what work they do. But but what they're not allowed to do now is they are not allowed to bill the other ancillary radiation oncology codes, which don't necessarily apply to surface radiation therapy, such as weekly management, such as our simulation family. And so they're now limited to the codes in their family. So that's also a really good thing for our specialty because it prevents other specialties from coming in and becoming the dominant user and us having to revalue our codes.
Yeah. And we've heard from some folks who might use a lot of orthovoltage, particularly for like non-malignant uh, indications. And CMS in the final rule noted those concerns that folks had flagged for them, and basically just said, like if this new code does not describe what you are doing when you're doing that, there's always the possibility of using an unlisted code, and so those folks who had those concerns were also heard. Um,
Yeah, and I would say that because I practice benign radiation, and I actually have a pretty busy practice doing that, and I use a linear accelerator to do that. So I use photons and electrons, and I'd say the vast majority of radiation oncologists who deliver that care are using linear accelerators. So they will use the new treatment delivery codes 77402 to 77412 for that. But if you're using an orthovoltage system, then you'll use the new X codes for that. And actually, the value of that orthovoltage has also gone up for our practitioners who are using that.
yeah, that's a great point. Yeah, the value of that did go up pretty significantly. Um, so moving on, one of the other big things that kind of impacted not just radiation oncology, but everybody who practices medicine was this efficiency adjustment. When it came out in the proposed rule earlier this year, highly unpopular with just about everyone. Um, but they went ahead and finalized it and are moving forward with it. Can you tell us a little bit more about how that works and how that's impacting you all?
Yeah, and so the efficiency adjustment is an interesting thing. And so their idea behind it is if as a physician, if you're doing procedures, the more you do a procedure, the more efficient you get at it. So eventually it shouldn't take as long as when it was a new procedure, when you were still new at doing it. And so they're saying that when these codes are created and go through the RUC process, They're valued when they're new. And yes, they're occasionally brought up for revaluations, but not always. And so it's not accounting for these efficiencies. That's the argument that CMS has made. And so what they did to address that is they just did a blanket 2.5% cut across the board for any proceduralists who are doing non-time based coding. Um, but that is not science. That doesn't really take into account what codes are actually being done more efficiently. Um, like I believe that what should have been, if they really were looking at efficiency adjustments, they should have studied the different procedural services, had input from the proceduralists from the different specialties, and we could have told them which ones are like we could have recorded time data and told them which ones are being done quicker or not quicker, and then actually had real science to look at how to create different cuts for these efficiencies. But to do a blanket cut across the board, I think really their goal was to do a cut. And me speculating as Amar Rewari, I believe it's because there's pressures under budget neutrality.
Mhm.
As proceduralists continue to increase and costs continue to rise for practice expense, it puts downward pressure on primary care because it's a budget neutral system, right? And so they want primary care to still be rewarded. And I get that. But I think the solution for that is to increase the pool. You need to have Congress make changes to allow primary care to get paid more for what they do, because what they do is so valuable. And it's not robbing Peter to pay Paul, but actually increasing the pool and doing real science behind if there's any efficiencies that are there.
Yeah, and we should note that it doesn't apply to every code in the fee schedule, but it is something like 91% of the codes will be impacted by this. They did exempt like E&M codes, maternity codes, anything on the telemedicine list got exempted, but still everything else is hit.
Right, which makes me feel it was more of just a way to redistribute to primary cares, because the ones that were excluded are the ones primary cares mainly bills, which is the E&M codes because they're not
Right.
doing procedures. So
Yeah, and it's just another example of kind of their push for funneling money more to primary care than the specialties
exactly.
over the last several years. So it's not a huge surprise. And that was also kind of a little bit old now, but it was one of the recommendations from MedPAC to Congress to do, I think back in like 2018. And MedPAC, for those that don't know, is the Medicare Payment Advisory Commission, and they advise Congress on all things Medicare. And so that was one of many options they had promoted in one of their reports, and CMS is implementing kind of a modified version. It's slightly different than what was in the MedPAC report years ago, but
No, what you're saying is absolutely true. We actually had Michael Chernow, who's the president of MedPAC, on our podcast this year. And
okay.
yes, he is very much was a proponent of this, as were the last several years of MedPAC chair. So while we are Astro working to try to join other societies to fight this, I do think it's going to be an uphill battle because there is support going back several administrations for this.
Yeah. All right. Kind of one of the last things I wanted to highlight from the final rule for Astro members and anybody else who may be listening is that some of those flexibilities everyone got used to during COVID have been made permanent, namely the option to do direct supervision virtually, and they are permitting that to be done with audio and video. They're excluding audio only, but audio video is permanently now allowed. And for just about every service provided, I think they're exempting from this flexibility certain codes with global periods. Um, but for just about everything else, they're leaving it up to the doctor's professional discretion on whether or not it can be performed virtually. And do you have any thoughts about that?
Yeah, I mean, on the one hand, as a somebody who works in the community, I obviously appreciate the flexibility, right? It's nice when you're trying to balance a lot of different things, and you're in one clinic and you're trying to do your weekly management checks on a patient in another clinic. Yeah, it's great to have that flexibility to give them a phone call or do it with a real-time audio visual, so you don't have to run back to that clinic. And I get the concerns that a lot of our members face around that, the practicalities associated with that. Let's say you have to run to a tumor board, or you have to see an inpatient, or something, God forbid, happened to your car that morning. So in the one-off situations, I think having the flexibility for real-time audio visual is a great thing. What I worry about is abuse, and just hopefully that people don't take advantage of this and end up having a model where radiation centers are going to be staffed 100% remotely with no radiation oncologists on site. That's not fair to our patients. That's not fair to our staff who are there every day to just have a radiation doctor supervise like 3, 4 different facilities across the state just to save the hospital a buck. So that's my one concern, and we'll see how it plays out, and time will tell.
Yeah, and just to enforce that that's for anything that required direct supervision. If it required personal or the more broad general, those are still how it is. But anything that
Yeah.
required direct supervision is pretty much virtual now unless it's exempted, like I said. Um, all right. Yeah, like we said earlier, this was just about the fee schedule. We're still waiting on the hospital outpatient rule. Um, there shouldn't be too many tricks in there. I think we'll be a little more interested in reading the agency's rationale behind the APC assignments for the new delivery codes that we were talking about earlier, because they straight up said we're not talking about that in the fee schedule. So we know what APCs they've linked the new delivery codes to, but we don't know exactly why. Because Dr. Rewari said earlier we had recommended some tweaks to those assignments in our comment letter after doing some big data analysis on our end. So we'll be curious to see what they had to say about those comments.
Yeah, I'm happy to be back on then if you invite me to talk about the hospital outpatient payments. And please check out my podcast also if anyone's interested in these topics. It's Value Health Voices.
All right. Thanks very much.
Thanks, Adam.